long time. My name is Nandita Naya, and I practice as a clinical neuropsychologist and a clinical psychologist. And as the co-founder, I have the honor of introducing you to Erisha, a vision that began a decade ago with a big dream and a deep commitment. Erisha started 10 years ago in Trivandrum, out of the home of Janaki Hari. What began as a small pediatric center slowly but surely grew into a space filled with laughter, learning, music, milestones, and above all, meaning. Before long, Erisha moved into a larger space. More therapists joined, many of whom are here with us on this call today. And more children came through our doors. Together, we built not just a center for intervention, but a community, a place where neurodivergent children and their families could come and sometimes for the very first time experience joy and celebration in spaces designed for them. We hosted learning circles, parent support groups, and carnivals, and watched friendships form, confidence build, and voices rise. But as with many things, the pandemic forced us to pause. Erisha, as we knew it, had to take a step back. And many of us then moved on to different workplaces and cities, some even to different countries. But our hearts were always with the families we had worked with and the ideas we had always dreamed about. Late night calls, long WhatsApp chats, always circling back to the same questions. What if we did this differently? What if we built something better? And what if we could go further this time? And surely this can't be as good as it gets. And so Erisha was reborn last year, not just as a center, but as a foundation, a movement, and a platform. The children we once supported are now teenagers and young adults, and their needs have grown with them. Families still have many of the same questions, only now they're bigger. How do I advocate for my child at school? What does independence really look like? Will they find a workplace that understands them? And who will support them when I no longer can? And we realize the questions may evolve, but the gaps remain. And to all those questions, Erisha is our answer. We are building what we wished had always existed, a dedicated support system that walks with families across every stage of life, grounded in trust, collaboration, and compassion. We recognize the deep disconnect and hardship that happens when systems don't fit the lives they're meant to serve. We also recognize that supporting individuals isn't enough unless we also support the systems around them, the therapists, schools, employers, caregivers, communities, and the larger environment itself, sensitizing, educating, opening doors, and shifting mindsets so that inclusion is not a special favor, but the natural way we live and work together. This conference is our first step towards that vision, a space where Indian voices are not just included, but centered, where therapy is not about fixing, but about flourishing, where families, therapists, educators, and advocates come together, not in silos, but as one collective. Welcome to Erisha, and we're so glad that you're here today. And before we begin, I'd like to take a few minutes to walk you through some of the guidelines to help us all have a smooth, engaging, and enriching conference experience. So each session will run for approximately an hour, 45 minutes for the speaker's presentation, followed by 15 minutes of audience interaction through a Q&A session. As a courtesy to our speakers, we request that you please keep your microphones on mute during the presentation. And if you're comfortable, do keep your cameras on. It really helps us all feel a little more connected, especially in an online setting like this. And our hope is for these sessions to feel participative and interactive and not just a one-way conversation. If you do have any questions during the talk, please feel free to post them in the chat box at any time. And we will try to address as many questions as possible during the Q&A, taking them in the order that they are posted. If there are multiple questions on similar topics, we will try to group them to make the discussion more seamless. And in the event that we're not able to answer all the questions live, we will follow up with the speaker and send the responses to you by email to the email address that you have registered with. And to help us stay organized, please ensure that your Zoom display name matches with the name that you have registered with. And this will help us correctly send you any follow-up answers and also your certificates of participation. For the certificates, all those who attend the sessions live across all 3 days will be sent the certificates. But if you do happen to miss a session due to unforeseen circumstances, you will have the option to access these recordings for any 2. And these recordings will be available for 1 month after the conference. And also, if you do wish to get in touch with any of our speakers after the event, please drop us a line at the Erisha Foundation at gmail.com or WhatsApp us at 9185-930-29905, and we'll be happy to help you connect. And with this, we come to our very first session for the conference, a topic that doesn't get nearly the attention it deserves, and yet it touches the lives of so many in our community. Up to 70% of individuals with autism will experience one or more psychiatric conditions in their lifetime, including anxiety, depression, OCD, and even psychosis. These conditions are often misunderstood, misdiagnosed, or simply missed altogether. And that's why this conversation is so important, and why we're so fortunate to have with us today someone who brings not just decades of clinical experience, but also deep compassion and insight. Dr. Jamila Koshy is a senior psychiatrist with over 35 years of experience in mental health. She completed her MBBS from the Armed Forces Medical College in Pune and went on to earn her postgraduate diploma in psychological medicine from Lokmanya Tilak Medical College in Mumbai. Her career has spanned multiple cities and settings, from serving in the Indian Army to working in leading non-government hospitals. Today, she practices at Baptist Hospital and Philomena's Hospital in Bengaluru. And what truly sets Dr. Koshy apart is not just her decades of experience and expertise, but her integrative, human-centered approach to psychiatry. She views mental health through a broad and inclusive lens, one that embraces the biological, psychological, social, and even spiritual aspects of life and well-being. In today's session, she will help us explore the co-occurring psychiatric conditions that often accompany autism across childhood, adolescence, and adulthood. She'll guide us in recognizing the signs, understanding the impact, and most importantly, learning how to support those who often face these challenges which go overlooked. And with that, I will hand it over to Dr. Koshy.
Thank you so much, Nandita. Am I clear, audible? Okay, thank you so much. Such a pleasure to be here with you at your first global conference on autism. I think it's a very good thing that you're doing this. And I wish you all the best as you go on with this project. And I hope that all of India benefits, not just random and care. Okay, so I will just share my screen and we will get right into it. Okay. Right, so as we all know, autism is this complex, multifactorial, difficult illness, really, which, well, not an illness, it's a neurodevelopmental disorder. The condition is so troubling because it affects not just the person, it affects the family, it affects the friends, it affects co-workers. It can have such a ripple effect on everybody. So it's very important for us to be able to understand this problem. And because of its very varied nature, studies into it and research into it are also still haven't yielded the sort of fruit that we would have hoped after years and years and decades of research. We are still fumbling in the dark in many areas. But yes, there is a lot of information that we have. It's better, that's definitely better than it used to be. So we have some things to go on as we figure out how to deal with all the ramifications of autism and autism spectrum disorder. Okay. So I've been asked to just talk about all the other disorders which can happen along with ASD. Okay? So all the other mainly psychiatric problems which can happen along with autism spectrum disorder, so that we can figure out how best to help our relatives, our friends, and our clients who have this particular problem. Okay, so we need to first understand a little bit, just an introduction, because it's the first session. I think you all know all this, but let's just go into it anyway, because it will also help us to understand these various other disorders that can coexist with autism spectrum disorder. So 1.6% of US children are supposed to suffer from this. We don't have proper statistics in India, but I would suppose it's roughly the same globally, 1 in 100 children perhaps. And of course, as we know, males are more affected than females. Earlier, it was thought to be around 4:1, but now perhaps 3:1. Girls are getting diagnosed more. Girls tend to camouflage their problems a little better because of maybe the better social interactions and all that, which are customary. But the thing is that autism spectrum disorder is just not one disorder. It's a multiplicity of disorders. It's multifactorial. And that is reflected sort of in the confusion about the name itself, isn't it? Earlier, we had so many names which have now been sort of contracted into autism spectrum disorder. We had pervasive developmental disorder, we had Asperger's syndrome, we had autism, we had all these things, NOS issue, PDD, NOS. So there were so many disorders which sort of spanned a range of severity, a range of symptoms, and a range of specifications. But now we sort of clubbed it all together, and in a way that makes it easier, because we know that there are genetic issues in all of those problems. So yes, autism spectrum disorder is a genetic disorder. In fact, it's highly genetic, it's highly heritable. In twins, identical twins have a concordance rate of up to 75 to 90%, which means that if one identical twin has autism spectrum disorder, it's possible, the chance that the other would have is 7 to 9, right, out of 10. So yes, there is a strong genetic factor here, but the problem is we can't pinpoint the gene. We can't pinpoint which it is, where it is. In fact, various studies have shown so many possible genes which could be responsible for ASD. For instance, there are genes on chromosome 2, 3, 7, 15, 16, 17, 22, and of course the X chromosome itself, in different combinations, in combination with these different environmental factors. That is how this works. So what are these environmental factors? Well, there is birth trauma. Okay, so birth trauma is important. It's many people with ASD have a history of birth trauma. Premature children are more at risk. That is also known. Parental age is relevant here. And this is one condition, of course, where the age of the father is as important as the age of the mother. So both parents, as age advances, the chance of having an ASD a child is higher. Toxins and drugs are also responsible sometimes. There is responsible in the sense that there is a correlation in studies. We do not know if it is causative. We're not as yet sure enough to say it with that certainty. But we do know that if, for instance, a woman has been receiving valproic acid in her pregnancy for bipolar disorder, the chance that the child would be born with who has ASD is slightly higher. Other toxins, heavy metals, all these things have also been implicated. Maternal health, nutrition is also implicated in many ways. For instance, folic acid is supposed to be protective. So people who get adequate and appropriate folic acid supplements have a lesser chance of developing, of having a child with ASD. Nutrition is important, the mother's maternal, metabolic, and the immune status of the mother. For instance, immune illnesses like asthma or various thyroid problems. If a woman has many of these, the chance of having a child with ASD is slightly more. The vaccine theory has been discredited, and this I must say, because I do not know how many people still believe this, that the vaccine that they thought was responsible for it. There was a study in the Lancet in 1998, and that has been completely discredited. It was based on fake data, and there have been large studies in countries such as the Danish study, which have completely discredited the idea that vaccines, the MMR vaccine in particular, are responsible for having a child with ASD. Okay, so what exactly happens in ASD? We're coming to the pathology of ASD. What exactly happens? It's important for us to have some kind of idea. And again, as I said, this is not clear. There are lots of studies, there's lots of research going into it, and we have clues, but we do not know exactly as yet. We do know that there are problems in the neurons of the brain. We do know, for instance, that the brain, there is an early spurt of brain development. The brain volume is very large in a child with ASD, but that stagnates and then it even goes into a stage of degeneration. We know, for instance, that there is a reduction in the number of astrocytes, a particular kind of nerve cell, but there is a hyperactivity of the astrocytes at the same time. We do know that the proteins which are required to make up the synapses between the neurons, that there is a particular dysfunction there, but we're not exactly sure which and where. Okay, so there is a lot of study which is going into it, and the final conclusion that we can draw here probably is that there is a multi-region dysplasia. There's a multi-region problem in the brain. It affects a lot of areas of the brain, and of course, depending on each particular ASD type. Sometimes the prefrontal cortex is more involved. Sometimes the cerebellum is more involved. The temporal lobes and limbic system can be involved. Okay, so these particular areas, they are, as we know, useful in various cognitive functions of the brain. For instance, the prefrontal cortex would be important in cognitive processes, in thinking, in rational discussion, in concentration, in attention. All these things are required. The prefrontal cortex is required. The cerebellum is involved in movement. So when there are movement disorders in people with ASD, it's possible that the cerebellum is involved. The emotions are regulated largely again through the limbic system and the temporal lobe, and these lobes are affected as well. So depending on where and how widespread the involvement is, you can have all these various problems in the brain and in the person. Of course, along with the neurons and the synapses, the nerve cells themselves, they regulate the neurotransmitters of the brain. And these are also largely involved in autism spectrum disorder. GABA and glutamate in particular have been sort of pinpointed as being problematic here. And we'll come to that later, because these neurotransmitters, for instance, are required in the whole process of sleep. And is that why people with ASD have a problem with sleep? Now, similarly, all these areas are also involved in the other disorders which we talk about, anxiety, depression, etc. We know that there is a neurotransmitter change, there are changes in the prefrontal cortex, there are changes in the limbic system in these illnesses as well. So there's a lot of overlap between all these things. So it's not surprising that all these illnesses coexist with ASD. Okay, so let's go to some of them and quickly check what happens and how we can identify them and what should be done about it. We should just know that at least 40% of children with ASD have two other conditions along with ASD, and 70% have at least one. What are these various conditions? I've listed them out here for you. Okay, and the first one, of course, which we should look at is intellectual disability. Intellectual disability is very common along with ASD. 30% of children with ASD also have intellectual disability. And there are some particular syndromes which are typical, okay, in this. Down syndrome is one, the Fragile X syndrome is one, tuberous sclerosis is another condition which often has intellectual disability as well as ASD, okay? And we won't go into details of all these, but just for your information that these are particular syndromes. But there are also many others which cannot be pinpointed to these very specific syndromes. There are others where the intelligence is maybe faulty, okay? So the milestones may be delayed, both the verbal as well as the motor milestones may be delayed in the child. And because of that, there will be a slowness in developing intelligence, in learning of all the life skills, in just the social development of the child, the emotional development of the child. All these things, as we know, would be slower in a child with intellectual disability as compared to the biological age of the child. So what should we do here? What is to be done? As we know, again, there is no treatment available for intellectual disability to cure it. And this is something which people often struggle to accept when they realize that their child is slower than other children. It takes a long time for them to accept that my child will always perhaps be a little slower in learning things than other children. But what is required, of course, is training in a supportive environment with full acceptance of the child at the child's own pace. And when this is done, both the intellectual disability as well as the autism spectrum disorder would have the chance to sort of, be handled or be managed by the person as well as the parents with the least possible difficulty. Okay, let's go to the next one, which is ADHD. Now, this attention deficit hyperactivity disorder is right now very much in the news, right? There is sort of a epidemic of people thinking that they have ADHD. Every now and then I get clients who come in and say that I think that I have ADHD. It's possible they're right because there are tests and scales and all available online. They do it and they think that they have it. But what is important here for us to realize is that a lot of people with autism spectrum disorder also have a concomitant coexisting ADHD. And again, it's not surprising because the same brain areas are involved. And as you know, the symptoms of ADHD are both the attention deficit as well as the hyperactivity. It's an and/or situation. You don't have to have both, but often people have both. Sometimes the hyperactivity comes down as the person gets older, but the inattention problems often remain. Now, the person with ADHD may be of normal intelligence, may not be again. So again, you can have intellectual disability, ADHD and ASD all occurring together in a person, or it may be just ADHD and ASD. It may be ID, intellectual disability and autism spectrum disorder. So it can be any of the combination of these. It could be intellectual disability and ADHD without autism spectrum disorder. So you can have a combination of any of these. So what happens here? How do you identify this in your child or your client? Of course, you would see that there would be problems with, just in brief, just giving you a few symptoms here. The attention deficit is kind of would manifest itself in academic disturbances, academic problems. The child may not be concentrating in class, they may not finish their homework, they may not finish writing anything on the board. The teacher may complain that they're always zoning out, okay? So they may always be sort of functioning at a lower level than expected, at the level of their intelligence. The child may be thought to be very intelligent, but not performing to that level of competence. The person tends to be disorganized, okay? So things are scattered, it's very difficult to put things in order, the room may be a mess, the bag may be a mess, they may forget things, they may lose things, okay? They may zone out in conversations, they may procrastinate on things. So all these are signs of attention deficit. Similarly, hyperactivity manifests itself in this excessive running around. Okay, so in some children, it's very obvious. They're just running all the time, okay, as if charged by a motor. But in some children, it's much less. They may be able to restrict the running around to only times when it's appropriate. Okay, they may just be a little fidgety excessively, but they may be easily distractible, they may be impulsive, they may speak too much, they may jump out of turn to take their turns, that sort of thing. So these are the symptoms of ADHD. Now, how do you handle it? Again, the most important thing is for parental understanding, okay? Rather than thinking that the child is either naughty if they're hyperactive or lazy if they're not paying attention. These are the two extremes that parents often think, that the child is lazy or the child is naughty. Well, it might be neither of the two. The child may have ADHD. So the parents need to be understanding. They need to be able to accept the child as they are. They need to be able to allow hyperactive children enough exercise so that they are not curbed, they are not frustrated by the restrictions that parents can impose on hyperactive children. At the same time, it is important to give them structure and routine, all right, so that they know that this is how I do it, that I tend to forget, so I need to have these things in place. I need to have reminders, I need to have lists, I need to have a clock in my room, I need to learn how to use the alarm on my phone, okay? They need to have frequent reminders, which they learn themselves to set up, okay? So that they can manage their lives. They need to be able to break up tasks into doable chunks so that they do not procrastinate and forget or zone out or go down a rabbit hole, which is how they often describe what they do, okay? So these kind of things are something which parents would need to help their children to do. And as a child grows up, they need to be able to do this on their own. Of course, pharmacology is also sometimes required, though we try to put it off, if it's a mild case. So nowadays, there is, as I said, a sort of epidemic of people coming in, hoping for help with this particular problem. Okay, coming to anxiety disorders. Now, anxiety is very common in people with autism spectrum disorders, and it's not surprising, isn't it? Because they have all these issues, no? They have problems in communication. They might want to make friends, but they don't know how to do it. They do not know how to read social cues. They may sort of misread things. They may have peculiar repetitive habits which others laugh at, and which after some time they also realize are something which is not common, that others don't do it. So they try to cut it down. Sometimes the sensory load can be too much. They may get frustrated with too much of noise and stuff. They may have these peculiar sort of a need for textures and all that, which they may not be able to handle. In many settings, these things are seen as crazy or as unnecessary, or as weird. So there can be a lot of anxiety in these people, in a very, looking at it from a purely psychological point of view. But if you look at it also from a etiological point of view, we looked at the brain, and the same areas which are responsible for the autism spectrum disorder symptoms are also responsible for anxiety disorders in other people, right? So a neurotransmitter problem, a problem with the frontal lobe, problem in all these areas can lead to the person's hypervigilance. Okay, so that sort of situation can come up in a person with ASD as well. So the thing is that because the person has autism spectrum disorder, we might overlook whether it is a disorder in itself, the anxiety problem. It may not be just an offshoot of the ASD, it may be an anxiety disorder in itself. Simple phobias, separation anxiety, anxiety in social situations, and generalized anxiety. These are the various kinds of anxiety disorders in the general public. And these same things can happen in people with ASD as well. Right? So we need to know all these things. Simple phobias, as you know, are phobias of maybe a dog, a cat, or some particular thing, an item, a thing, often an animal, or some kind of setting. Separation anxiety is when the child is extremely anxious if he's separated from the parents. Anxiety in social situations is seen in people across the social spectrum. People who cannot speak in public, or they cannot go to a wedding, they cannot speak in front of elders or teachers, right? Whereas a generalized anxiety is a state where you are in a anticipatory, negative or hypervigilant state across the spectrum of your life. So at home, at school, at play, at night, everywhere, you are irritable, edgy, restless, expecting the worst to happen, just having the sense of vague doom approaching. All right. So this kind of thing can happen even to people with ASD. Now, sleep disturbances are common in anxiety, and it can be common in people with ASD as well. Of course, in anxiety, there often are a lot of physical symptoms in the general public, and this can happen in people with ASD as well. So you can have tremors, you can have sweating, you can have pain in your chest, you can have, just a sense of wanting to go to the loo all the time. You may have just this kind of repetitive walking up and down. Okay, now this can overlap and can be confused for the repetitive movements of autism. So we need to be able to separate this, and we need to have our antennae up that is this person more anxious than usual? So if it sets in and it increases at a certain time, then you need to think whether there is an increase because of a coexistent anxiety. Also, we need to know that it can correlate quite a bit with parental stress as well. And some studies have shown that maternal stress, because the mothers are often the primary caregivers for the child. So the maternal stress also can cause the stress or the anxiety to rise in people with ASD. Now, how do you handle it? First, again, as I said, acceptance of all these various tricky aspects of autism, learning to live with the needs of the person with ASD, accepting this and accepting that there would always perhaps be certain restrictions and certain things that are different in your family. Accepting this and handling this anxiety at both the parental as well as the child level would be important. So it would be important to go for therapy, perhaps even to take medication if required, so that life can be handled and come down to a calmer and a more peaceful way of living. All right, it can be done, so we should not overlook it, because if overlooked, anxiety often goes into depression. When you have stopped anticipating the worst and you sort of feel that you are in the worst situation already, that there is nothing worse to look forward to because I'm already in that situation. Life is already as horrible as it could be. So that sense of sadness, that sense of despair, the sense of losing interest in whatever they liked earlier, being withdrawn, perhaps not talking as much or not interacting with people as much. Okay, a constant feeling of negativity, a loss of good feelings about yourself, maybe a feeling of guilt or hopelessness or feeling of helplessness, a feeling of just not maybe even wanting to live. Okay, so this kind of depression also, unfortunately, is more common in people with ASD. It can be from 14 to 30% of people in different studies have shown depression. Okay, and again, as I said, it's often overlooked because everybody is stressed. So we sort of say, life is like that. And we just got to kind of take it as if it is not something which can be handled or treated. But it can be handled, it can be treated. So it is important for us to recognize this when someone is depressed, either the parent or the child, by the way, or the person with ASD. And psychotherapy, particularly cognitive behavior therapies, can help. Medication helps depending on the severity. And this is something we should not ignore and overlook. Okay, coming to the next disorder, which is obsessive compulsive disorder. Now, obsessive compulsive disorder is actually part of the anxiety disorders, but I've mentioned it separately because it is in itself very common in people with ASD, and often it can be confused with the repetitive behaviors of ASD, because people with ASD also have certain repetitive behaviors, no, of different kinds. They may pick things up, they may move their limbs in a particular way, they may want to put things in a particular way. So there may be repetitive movements, hand flapping or banging, or all sorts of repetitive behaviors, which can be confused with the repetitive actions of OCD. Now, OCD, obsessive compulsive disorder, is the occurrence of repetitive, intrusive, unwanted thoughts. Okay, so the thought may be that my hands are not clean, so I need to wash it. Okay, my hands are not clean. So the thought is what? That my hands are not clean. I could develop some kind of disorder. I could develop some kind of illness. So the thought causes anxiety, and it requires an action to negate it. So if the thought is that my hands are dirty, the action required is perhaps washing it. Now, when you wash it, another thought will come in that I haven't washed it enough. So this thought will come in. So I need to wash it 3 times. So that could be the additional obsessive thought, that I need to wash it 3 times. So if you wash it 3 times, then the compulsion is satisfied that, okay, I have done it and this is enough. And you may go and sit down. But after half an hour, it may come again that I need to wash my hands again, because I may have touched the table, I may have touched the door, I may have touched a note or a coin or something like that. So again, the thought comes into the mind and there is this need to do it. So the difference from the repetitive actions of ASD and the compulsions of obsessive compulsive disorder is that these are unwanted thoughts which cause anxiety. Whereas the repetitive movements of autism, they are a sense of sameness, there is a sense of comfort to the person. They don't cause anxiety. Okay, so that is the difference. And usually they start very early, the repetitive movements of ASD, whereas obsessive compulsive disorder usually sets in later. Okay, so it happens later, and it's usually connected to some situation or context or some particular thought. And most importantly, it is unwanted. It is not something they want. It is something they do not like and they're scared of. So this is an important thing. Again, OCD is quite common in people with autism spectrum disorder. So we need to be able to differentiate that, okay, this is the repetitive behavior and this is the OSD, and both need treatment. Again, how do you treat this? Behavior therapy is one way of treating it. Okay, some people with mild symptoms may settle down with just behavior therapy. Some people may need medication, and usually it's required for if the problem is very severe, do not hesitate to give the medication which is required, because it will bring a lot of comfort, because OCD can be a very troubling illness in itself. Okay? Uh, on the surface, there's nothing to see, but internally, it can drive people very, very, it can drive them really up the wall. Okay? Right. Now we come to oppositional defiant disorder. Oppositional defiant disorder is one of the behavioral disorders which can happen also with people with ADHD, with ASD. Okay? So these behavior disorders, they happen in children. Okay, and what are the symptoms of this? You might find that the child is very easily angered. The child may have these outbursts of temper. The child may argue with the adult. The child may refuse to obey rules. The child may blame others for their own problems. They may do little vindictive or spiteful things like hurting someone, or doing some kind of harmful thing just to get their own back if they feel that they have been blamed unfairly, or something like that. Now, why do these things happen? Now, again, uh, this is there is a psychological explanation, and there is the always existent biological substrate on which this forms. Because we notice that these things happen more when there is a biological substrate of anxiety, ASD, or some of these other things. But at the same time, there are the psychological and psychosocial aspects of it. Because the children might not be uh, allowed to, have their routines. Maybe they struggle with social issues with other children, or they struggle with their sensory problems, all the particular things that they want to do and the way they want to do it. They want to hold this particular item, or they need this particular toy, or things like that, which can cause problems if they are not allowed to do it, or people laugh at them, or whatever. So this might result in the child developing the oppositional defiant kind of syndrome, where they fight, they easily get angry, they sit with their hands like that, they talk back, they create a problem, they disrupt the classroom. So this can happen across the spectrum, in class, at home, okay, everywhere. And when it lasts for a long time, it becomes this kind of problem. So how do you sort this problem out? In order to deal with this problem, again, parental acceptance is the most important. Parents need to understand that these children have a very, in a sense, a very difficult life, because their needs are different from the needs of most children, and their particular uh, their particular needs can seem very bizarre, and not everybody in the family may accept this. They may say that, oh, why you carrying that toy around? You're a big boy now, throw it away. Okay, so somebody may react like that, no? Whereas that particular texture might be bringing a lot of comfort to the person with ASD. So parental acceptance and understanding of the child's needs are most important. There should be adequate communication to understand these needs, and you have to put in place structured routines, okay, to calm these kind of children down. Because as it is in ODD, this is required, that you need to be able to understand why the child is angry, catch the problem early, talk to the child to understand what is happening, read the cues, read the psychosocial setting, do a proper family study of what's going on. So all these things are required. And in a child with ASD, all the more reason why you need to have these structured, calm routines, okay, where the child is allowed to have their space, their particular thing. And at the same time, you keep communicating to understand and try to make these things as less troublesome as possible. At the same time, we need to give positive reinforcement for good behavior when there is appropriate and good behavior, as in not getting angry, not blaming others, accepting the rules, doing whatever's required in the particular family setup. There should be praise and recognition of the good behavior that should be caught and praised, given positive reinforcement, so that the child is encouraged to carry out the same thing again and again in order to get that same kind of reinforcement. Whatever instructions are given, again, should be given in very clear blocks of instructions. If you just say, go to bed, that's not enough. No, you need to say, okay, go to bed. we need to go first. I need you to put on your pajamas. I need you to fold them and put them away here. Okay, so we need to give clear, doable instructions in chunks, okay, which are doable. So if these kind of clear step-by-step instructions are given, the child is better able to do it. Any child with ODD, and all the more children with autism spectrum disorder as well. Okay, conduct disorder. Now, this is a slightly, slightly more problematic in that sense, because along with the anger, there is also aggressiveness, destructiveness, sometimes a lot of telling of lies, okay, violating rules. And this kind of whole behavioral syndrome is accompanied by what we think maybe a lack of remorse and very shallow emotional thing. Like the child is not sorry or anything because they've sort of made themselves immune to that. All right. But this can coexist with ASD as it goes on. Okay. And it is by in itself a problematic situation, and often it can lead to antisocial personality disorder, which is again a problematic situation. So you require detailed psychosocial and interventions here, where you need to study what's going on, why this kind of family setup has happened, why the child with ASD has gone into this, and you might require different kinds of strategies to deal with the conduct problem. Okay, now coming to what is called gender dysphoria. This is where a child with a biological sex of one gender is uncomfortable with their being placed in that gender and feel that they belong to the other gender. Okay, so gender dysphoria. Now this is 3 to 6 times more likely to happen, okay, in people with ASD than in others. And again, this is not surprising to me because there is a lot of discussion about trans people right now, and there's all sorts of nonsense which is being said by people across the spectrum about it. But as in the case of so many other illnesses which turned out to have a biological basis, I'm pretty sure that gender dysphoria also, there are lots of indications that there is a biological basis for this. And this itself, the high incidence of gender dysphoria in autism spectrum disorder points to that people with autism spectrum disorder are 3 to 6 times more likely to have this discomfort with their assigned gender. And interestingly enough, and we do not exactly know why, this usually happens in females. Now, as we know, the people with ASD are more among men than more among boys than girls, but this is more likely to happen among the girls with ASD. They are more likely to feel that they are not girls, but they need to be boys. Also, it's interesting that people with autism spectrum disorder are more likely to have a homosexual orientation rather than a heterosexual orientation. This has also been studied. Now, parents need to be aware of this. Okay, we do not know exactly why this happens. Possible biological reasons, as we said, all the etiology, all the problems with the different areas of the brain. For whatever reason, parents need to be aware of this and prepare themselves for these conversations, because they're not conversations that Indian parents in particular are very comfortable with. Okay, and we have our own social norms and rules and all that, and we may not be very comfortable with this, but we need to be prepared for these conversations and the life changes that may happen. And again, acceptance and support of the person is essential. Okay, and feel your way, get whatever help you need, and this is how to handle it. Okay, coming to sleep problems. Sleep problems are another area where people with autism spectrum disorder often have a problem. And the problem can be pretty global in the sense that falling asleep is a problem, staying asleep is a problem, waking is a problem, REM sleep, that is, the sleeps with dreams and sleep without dreams, that REM sleep is also a problem. And so there can be a range of problems within this whole area of sleep. People with ASD can have all sorts of problems. And we are not, again, completely able to pinpoint why this happens, but we have certain clues. For instance, the neurotransmitters have a problem. GABA, GABA definitely has, there is a dysfunction of the GABA system in the brain that is important in maintaining sleep. So that has a problem. Melatonin, which is required in the proper circadian rhythm of sleep, that sometimes has a problem in people with ASD, and that could be the reason why they have sleep problems. Also, we've just studied, we just looked at the fact that there are a lot of coexistent disorders. For instance, anxiety, depression, ADHD, all of these can have problems with sleep. Okay, so because of that, that may be the reason for the sleep problem. But then there is also the psychosocial reason of parental stress. Parental stress can also lead to the child not being able to sleep properly. So what do we do about these things? Again, we need to sort of examine this properly. It needs to be discussed with the therapist, the person who's giving you care, and we need to do various kinds of interventions. Okay, sleep hygiene is one, for instance. Just making sure that the place that you sleep is earmarked for sleep, okay, and it is a calm and peaceful place. The temperature should be right. It should not be too hot. It should not be too cold, okay. Though a little on the cooler side is probably better. At the same time, there should not be bright lights and a lot of distractions. Maybe a TV in the bedroom, screen time late. All the things that we do for sleep problems for any child would be what we would need to do for children with ASD as well. But particularly, again, these structured calming routines with, again, structured. So you need to sort of have a system that, okay, some people may say you have a wash before you go to bed, or you fold your clothes and put them away. You take your pajamas and put them on the bed. You put them on. Perhaps then we come and read you a little story, and then we give you a kiss good night. There may be a routine that happens. Okay, so build these structured calming routines into the child's or adult's schedule, so that there is a tendency to fall asleep easier. And then, of course, if nothing else, if this doesn't help enough, sometimes pharmacology is also required. Some medications can be given. Okay, I'm taking one more here, which I didn't mention earlier, but seizures. Seizures are also common in children or adults with autism spectrum disorder. Up to 20% of people can have concomitant seizures as well. As we know, seizures are because of what shall we say? It's a sort of electrical short circuit in the brain. Perhaps that's the easiest way that it's defined. That there is a firing of neurons, which is at the inappropriate time and place. So there is a sort of convulsion, a loss of consciousness, perhaps, and because of the loss of consciousness, there is a loss of muscle tone, and you may have, urination at that time, or even defecation, whatever. There might be a sort of episode where the person loses consciousness, has movements, generalized tonic-clonic movements, or movements only in one particular hand or leg. That is a focal seizures. You may have just staring spells, okay, petit mal seizures, where just the person blanks out for a second or two. They may or may not fall, okay. So this kind of seizures may happen. Or you may have discrete episodes of strange behavior. Okay, these are temporal lobe seizures, where you might have some repetitive sort of movement, some kind of stylized movement of hand or mouth or something, where there is a seizure in the temporal lobe. It can cause this kind of, there's no loss of consciousness, but there's a loss of connection. The person may not be aware of what is going on. They may speak at random, say something weird. Okay, so these discrete episodes may also happen. As required, investigations need to be done. Okay, starting with an EEG and a CT scan, an MRI, maybe a metabolic workup, perhaps a genetic workup. All these things would have to be done to investigate why this is happening. And as required, pharmacology would need to be given, because often these people with seizures would require regular and very consistent medication. That is almost always a must, because otherwise each seizure damages the brain. So that is not a good thing. And of course, there would also need to be lifestyle changes. For instance, driving may not be safe, swimming may not be safe. So there are certain things which need to be built into the lifestyle to change things. Okay. I've covered all the various illnesses. I'll just run through them again. We talked about intellectual disability, anxiety disorders, mood disorders, obsessive compulsive disorder. Various kinds of behavioral disorders, sleep disorders, gender dysphoria, and seizures. Okay, so I've discussed these various issues which can happen at any time in the person with ADHD, with ASD's life. and they need to be handled. And we do see them quite frequently, okay, these various conditions. And let's hope that as we discuss this, your awareness of these things improves a little bit. And I stop here and open the time for questions. Handing it back to you, Nandita.
Thank you so much. So we've got a fair few questions. What I'll do is I'll take them in the order that they've come in. So the first few questions have come in from Manjari. And what she's asking is, are there any medical tests that should be performed by a doctor when making a diagnosis for autism? And then she has a follow-up question around what are some of the common autism screening tools that are used today? And are there any tests that are not recommended for the diagnosis or management of autism?
Well, see, autism is basically a clinical diagnosis. Okay, there are various scales which are used. Okay, for instance, the DSM-5 itself has a detailed scale which you can use for the diagnosis of autism. But the thing is that tests need to be done sometimes when there is a suspicion that there are other other syndromes at the back of it. Okay, for instance, if there's a genetic problem like Fragile X syndrome, or if there is Down syndrome, or if it is by any chance Rett syndrome. Okay, so there are different allied illnesses which could sort of coexist with autism, in which case you need to do all these various tests, and that is how it is. Okay, so but basically it is a clinical diagnosis. You need to go and get the child assessed properly, and if you go to most of the child development centers in a good largish hospital, you should be able to find these. Okay.
The next question is from Amrita Ranganath, and she's asking, are mental health issues or behavioral issues such as OCD, ODD, depression, anxiety, neurodevelopmental disorders, or do they develop or co-occur due to an unfavorable environment? If they are gene neuro-related, are they likely to occur even with acceptance therapies or a supportive environment?
Uh, yeah, no, they are not neurodevelopmental disorders. These are more like illnesses. Okay, they're more like disorders which happen afterwards. They don't happen at birth like autism and ADHD, which are neurodevelopmental disorders. These happen later. Okay, so they are. What did you say? Does it come off itself, or does it happen because of a lack of support? Well,
Yes.
it's difficult to say that always. Okay, there is often a family history of these things as well as of ASD and ADHD. So if there's a family history, we know that there's likely to be a biological substrate there. Many of these illnesses have a genetic background to it. Okay, so the genetic background would be important here. So it's not just the lack of support or anything like that. There is a genetic tendency towards it. And all these illnesses tend to coexist because, as I said, there is a biological problem in the brain. And if you can have one problem in the brain because of a problem in the in the cells and all that, you can have another as well, right? So that's how it is. But then they can always be worsened by a lack of support, by a lack of help, by a lack of understanding, by a poor environment. Definitely, it can worsen all these things. So that's the best answer I can give.
And the next question is from Rashmi, and she's asking, how can I best support my child with autism in learning about their body, sexuality, and healthy relationships?
Well, again, see, having good communication with the child is important. So the way we would explain it to a child without ASD is that, you at some point, when they ask a question, you would follow it up with, suppose the child was to ask, uh, when a puppy is born, the child may ask, where did this puppy come from? So then you sort of give them an example that this is the mummy and she's had this baby, or whatever it is. You take the cue from what the child asks you, and you use that as an occasion to explain about sexuality and all that. The same thing with the child with ASD, but you would probably need to be a lot clearer, and you'd probably need to be you'd need to break it up a little better You need to give a lot more of visual structure to it, okay, so that the child can understand. That's probably all that you need to do. You need to sort of help them to accept themselves very positively, okay? You need to be able to teach them about their body in the sense of good touch and bad touch, just the same as you would teach a child without ASD. That, you know, because every child is vulnerable. They need to know that this is my body. I am happy with it. I am proud of it, and nobody can touch my body except me and anybody who I allow to touch my body. So, like my parents or the doctor or a special person who I might relate with. So, I was trying to, I'll just have to tell you about which scales are best used, okay? See, I don't routinely do the diagnosis of it. I usually get that done by the child psychiatrist, okay? So they usually come to me when they're older. So I'll have to check up and tell you the scales. Kavita, if you know which scales are used for children, you can always put it on the group, okay?
I mean, as
I
a
don't,
psychologist, I think we rely
I use
quite heavily on the ADOS.
Yeah, I use a clinical diagnosis and then they are referred to me as adults. Okay. So I don't use the children's scales. So if you know any of the scales, you can tell them.
Sure. Okay, so we'll just move on with the next question, which is again from Amrita. And she's asking this question in the context of a student of hers who was waiting to have a sex change operation at 18. And her question is there any law in India regulating gender dysphoria or changing of one's sex?
Law in India. I don't think there are too many laws in it because see we have a large Hijra community and they are doing it without any restriction at all, as far as I know. I'm sorry, I'm not aware if there are any laws. Okay, we'll probably need to check that up. I would think that some hospitals who are used to doing the sex change operations, there are a few who do. They would probably be clued into if there are any laws. As far as I know, there are none.
Swati's question is the next.
You'd probably at the same time have to, this much I know, that if you are applying for a change of name or anything, you'd probably have to put a notice in the newspapers and say that I would be known as this from now on. So that probably would be required. So change of name, all the legal part that goes into that would probably need to be followed here as well. Okay.
Shall I go on to the next one?
Yes.
Okay. Swati has asked a question about her son who's 6 years old. And she says he's been given therapy since he was 2 years old. He has a problem with concentrating, but he's not hyperactive. And he has a problem with routine change. His cognitive skills are very high and can understand our emotions well. His speech started with two word level, and just 4 months ago, he also started using Avas. I would like to know what is his problem. Is this ADHD?
It looks more like ASD. Okay. So please go and get him assessed properly. Because he has a problem with communication, right? He has a problem with communication. He has a problem with emotional connection. You're saying that does he have any repetitive behaviors, any sort of motor activities, any any sort of peculiarities of interest or anything like that?
Swati, would you like to unmute and answer that?
She said, yes, ma'am.
She said
yes.
yes. Okay.
Which is why it looks more like ASD. So please just go and get the child assessed properly.
Next one's from Rukmini, and she's asking, does a mother's postpartum depression cause autism in a child?
No, it doesn't cause autism in a child. Okay, we should be very clear that a mother's postpartum depression doesn't cause it. We do not use that specific word at all because, as I said, we are not clear about the etiology of it. We just know that certain things predispose to it, and there is a linkage in research. For instance, we know that if children, if there is maternal infection or maternal metabolic problems, the chance of having a child with ASD is higher. That's all that we are going to say at this point. We're not going to say that the depression caused the autism. Okay, because there are multiple reasons. There is a genetic substrate. As I said, there are a lot of genetic problems which interact with these other things, and that is what causes the problem. Every woman with postpartum depression is not going to have a child with ASD, right? There has to be other factors which combine, and that may lead to that. That may have been a contributory factor. That's the best that we can say. Okay, so please, nobody should blame themselves or anything like that.
Amrita has asked another one. She said, I'm interested to know about ASD and Down syndrome and or intellectual disability. Individuals with autism are typically very strong on visual perceptual skills, and many have strong skills or savant skills in music, dance, arts, and etc. Do these individuals who have ASD and Downs not have the strong skill set shown above? For such a child, there won't be a loss of skills around the age of 1.5. Is that right? And since they would show developmental delays since birth. So would they present differently is what she's asking. So if it's autism and if it's autism with Downs, would the developmental trajectory look different?
Well, the effect of both would be there, right? And you can't predict again what's going to happen. It's not absolutely necessary that there would be a sort of savant nature in either condition. It's not necessary. Nor is it necessary that there would be a sort of predominance of either. We can't say. It really would depend on each individual child. Okay, we cannot predict how the interaction of these two would happen. That's the problem. That's the problem with this. We can't really predict that if there is Downs and ASD, will that lead to this particular thing? We can't say for sure. Okay, but we do know that they coexist. We do know that a child with Downs tends to have intellectual disability, but they tend to be generally very sweet-tempered, children with a tendency to like music and be interested in certain, particular interests. We do know that children with ASD tend to have fixed interests, but we don't know what they are. No? We're not sure that it has to be this or that or the other. So we can't predict exactly what will happen.
The next one is by Soni Gill. She has shared a reflection and she says it was so useful to learn how to distinguish between stereotypies and behaviors and anxiety and looking for the subtle changes in frequency in behavior. And she's also shared a few of the scales that we were talking about earlier, as has Shailat Srijit. As a question, Namita has asked, how do we explain regression following a major illness?
Okay, regression following a major illness could happen if the illness was affecting one's brain. So if it's a meningoencephalitis or something like that, or if there were a lot of seizures which damaged the brain, okay, status epilepticus, that sort of thing, or if there was, even things like Rett syndrome tends to cause a regression after a certain while, which we may link to infection, which actually may not be the cause. It may be the genetic syndrome itself. So there may be various reasons why there is a regression. We'll really have to investigate and see, but usually these are the major causes of a regression.
The next question is by Arvind, and he's also asking about the assessment and the test. So he says, in addition to the regular questionnaires based for the autism assessments, are there any blood tests, brain scans, or checking for gut health that they need to do? We have a 9-year-old son with ASD.
Right. So see, none of these are routine. It doesn't need to be done, but if there is a specific reason why you think that the child has some problem which will show up in the CT or the MRI or whatever, then it would be advised. For instance, most children would not show these changes that we are talking about. These are not at the gross level which would show up on the MRI. Okay, they are smaller changes. They are cellular level changes which do not show up. So there's no point in doing an MRI routinely in all children with ASD. That is not required. But if there is some particular reason why we think there is one of these syndromes which may have, for instance, tuberous sclerosis, you may have a sort of tumor in the brain, some kind of outgrowth in the brain. That may be the reason for some of the problem. So in that case, we would require to do it. the gut stuff, no? The gut microbiome, for instance. If the child is having a lot of gastrointestinal symptoms, which a lot of children with ASD do, they may be having diarrhea or constipation, or they may have these frequent infections. It is possible. There is a theory that the reason for ASD is an alteration in the gut uh, gut brain axis, okay, that there is a change in the microbial environment in the gut. But these are all at a theoretical level right now. These tests are not routine. Okay, they might be done sometimes in a research setting, but not in a routine basis.
Thank you.
Rani Marcos has asked, many of the children are gifted. Do we need to focus more on those areas rather than train them in other subjects also in an inclusive setting?
Yes, definitely. Whether they're gifted in one area, please, by all means, help them to develop that area, because every child needs to have the confidence and the happiness of being good at something. Okay. So every child would benefit from allowing them to follow their passions and things that they are good at. So by all means, do that. That doesn't mean that you have to take him out of any kind of other training. All right, try to have a global training so that they learn life skills which are relevant to all areas of their life, so that they can manage as best as they can on their own. But of course, stress the areas that they like and they're gifted at.
Smriti has a question. If the mother of one has been under medication for anxiety, depression, or any other psychiatric disorders in her lifespan, does a second pregnancy have a higher chance of having ASD?
I'm not sure I know whether that is right or not. A second pregnancy, if they're taking, well, what we do know is that certain drugs can have a linkage with a higher incidence of ASD. For instance, we know that the treatment, the valproic acid, which is given for bipolar disorder, that has a slightly higher linkage with ASD. So usually, therefore, when a woman has bipolar and is wanting to get pregnant, we always stop that medication. We tell them that if you're wanting to get pregnant, please tell us and we will taper off this medication and put you on something which is safe, so that you don't have any kind of risk. It's not just ASD, there are other risks as well. Valproic acid is not given in pregnancy. Okay. But otherwise, just having depression does it cause ASD? There is no study as far as I know which leads to that. Okay.
And just the last question for today. Are there any prognostic scales or markers for ASD?
Prognostic scales or markers for ASD? No, again, I don't, I'm not aware of any prognostic scales or markers. We do know that, look, people with ASD who would probably do better are those who have a mild form of illness, okay, who don't have an intellectual disability to go along with it, do not have ADHD to go along with it, who have a supportive environment, okay, who have, parents who help them, who have adequate financial resources so that they can go to the appropriate school, this sort of thing, okay? So there is no scale, but if you look at all the stuff that I have said, you can put it all together and see that if we are able to meet these various needs, no, then it's obviously easier and there is a better prognosis. If, for instance, you look at a child from a rural setting where there is no school which focuses on teaching children with autism, okay, where there is where the parents are not able to give the time to sort of take care of their particular needs, where they might get laughed at or bullied or teased, then obviously there's going to be a worsening, there's going to be addition of anxiety, depression, whatever it is, and that would sort of make it worse. Again, a clinical understanding of this is probably what we all do routinely. We don't always use a scale.
So just in the interest of time, if anybody else does have any questions, if you could put it in the WhatsApp group or email it to us, we'll get all the answers with Dr. Koshy sorted and we will email them back to you. So, and I think what we might do is we'll just close here. And I really want to thank you from the bottom of our heart for a really insightful and very thought-provoking session. And it was a very complex topic, but you've broken it down so nicely for us. And this is an area which is overlooked so much. And I really want to thank everybody who's joined us here today for listening with openness and asking such important questions and making this session truly valuable. And we look forward to seeing you all tomorrow for another lineup of equally rich sessions that will continue to deepen and expand our understanding. I'll just quickly take you through the schedule for tomorrow. So we'll start at 10 a.m. with Dr. Roshandeep Bagga, who is a highly experienced occupational therapist. And he's known for his very thoughtful, practical, and deeply empathetic ways of working with children and families. And he'll be unpacking how sensory needs impact behavior, learning, and emotional regulation. And most importantly, how we can support children through effective sensory diets. And then at 11:15, we'll move on to what promises to be a deeply engaging and thoughtful conversation between Birinder Kalra, a senior special educator at Vasant Valley School, New Delhi, and Janaki Hari. Together, they'll explore the evolving role of special education in today's classrooms, why it matters, how it's often misunderstood, and most importantly, how we can reimagine learning to be more meaningful, inclusive, and truly accessible for every child. And drawing on their years of experience and a shared passion for child-centered education, we really hope that this session will leave us with fresh perspectives and practical insights. And the final session for the day will begin at 2 o'clock, where we'll hear from Sudarshan and his parents as they share their inspiring journey, one that's been marked with quiet determination, small but very meaningful victories, and the unwavering support of the family. Sudarshan is also on the autism spectrum and lives with low vision, now works in the corporate world while pursuing his passion for music. But getting here hasn't been easy. And this session is a chance to understand what growth really looks like over time, with all its ups, downs, and the in-betweens, and why creating the right support system around a person can make all the difference. So we'll see you all tomorrow. Please do try and log in by 9:55 so we can start on time. Thank you and have a wonderful rest of the evening.